Welcome to the Better Man Clinics, the podcast where we talk to actual experts to address the questions that men want answered, but are either too embarrassed to ask or simply don't know who to ask. Before we get started, I do want to caution that the conversations on this podcast are for informational purposes only. They don't represent a medical consultation, nor do they present medical advice to individuals. Rather, we hope that the podcast empowers men with the knowledge and confidence to address these issues with their healthcare providers. As with any medical or wellness issues, you should always consult with your healthcare provider before beginning any type of treatment or preventative intervention. With that being said, in today's podcast, we discuss a type of laser surgery called HoLEP as an option for men with urinary symptoms caused by an enlarged prostate, a condition called BPH that we discussed in a previous episode. Historically, when men either no longer benefited from prostate medication or could not tolerate the side effects of these medications, the next step would be a TURP surgery, otherwise known as a Roto-Rooter. Recently, however, new surgical options have been developed which are believed to provide results that are similar to or better than TURP and that are potentially safer and have less side effects. One of these newer procedures is a laser surgery called HoLEP, which stands for holmium enucleation of the prostate. Joining us today to help us better understand the risks and benefits of HoLEP is Dr. Amy Krambeck. Dr. Krambeck is a professor of urology at Northwestern Medical in Chicago, Illinois. Her urology residency was completed at the Mayo Clinic in 2008, and she subsequently completed an endourology fellowship at the Methodist Institute for Kidney Stone Research in Indianapolis, Indiana. Dr. Krambeck worked as an endourologist at the Mayo Clinic from 2009 to 2016, at which time she joined the staff at Indiana University and ran the benign urologic diseases division until 2020. Dr. Krambeck specializes in the surgical and medical management of stone disease and BPH, and has performed approximately 3,000 HoLEP procedures. Who better to help us understand this procedure? And now, without further ado, I bring you our conversation with Dr. Amy Krambeck about HoLEP as a surgical option for BPH. Talking about a procedure called HoLEP, which is a newer surgical procedure used to treat the symptoms caused by an obstructing or enlarged prostate, a problem that afflicts millions of men in this country as well as around the world. And we are so fortunate to be joined by really one of the foremost experts on this HoLEP procedure, Dr. Amy Krambeck. Dr. Krambeck, welcome to the program.
Thank you for having me.
Thank you. This is going to be a treat because we really want to hear from the experts, and you are definitely one of, if not the expert. Just for everyone listening, before we went on the air here, Dr. Krambeck was mentioning that she has performed nearly 3,000 of these procedures. And so this is really a treat for me to really better understand this procedure. And I'm sure everyone listening to hear it from someone who does it every day and really can give you some real insight as to what the experience is like. Now, what I like to do before we jump into the issue at hand is, I talk to a lot of experts, and I'm sure that the audience would be interested to know what inspired you to go into the field of urology and to do this in particular.
Well, I get asked this question a lot. And when I went to medical school, I liked working with my hands. I grew up on a farm and And so I wanted to be a surgeon. And during my rotations, I did a urology rotation to get more surgical experience and realized that I really liked the personality of the urologists. They're pretty fun-loving, laid-back people, don't take life too seriously. And I felt like my personality fit with their personalities a little bit better than just general surgery. So I switched to urology and never looked back.
That's amazing. Well, I hear that. I mean, I'm a urologist too, but I share that sentiment for sure. You have to have a little bit of a sense of humor and enjoy life, right? That's for sure.
Exactly.
If you're in this field, especially. So jumping into the topic of HoLEP, I want to take one quick step back. About a month ago, we did a podcast episode about the concept of BPH, or benign prostatic hypertrophy or hyperplasia, basically an enlargement of the prostate. But for those guys that are just tuning in for the first time today, could you just take a minute or two just to explain what BPH is and what HoLEP is treating, if you will?
Yeah. So BPH is something that occurs naturally as men age. So just like how our nose and ears get bigger every year, so does your prostate, unfortunately. And, it's just one of those things. And as it enlarges, in some men, it can constrict the urethra. So the urethra is the tube that you urinate through. And it connects the bladder to the tip of the penis. And the prostate acts like a donut around the urethra. So as it enlarges, it can squeeze down on that tube, just like kinking off a water hose, and can make it very difficult to urinate. So HoLEP is a surgical procedure that uses a scope with the man asleep. We use a scope and a laser to core out the inside of the prostate through the urethra and open up that channel. So by coring out all of that tissue, I can get you back down to where you were when you were a teenager. And you will urinate again like that. And urination will no longer be something that you're worried about doing or planning your day around. It will just become a natural function again.
Right. It's kind of amazing when urination becomes the center of your day. So this could be a real gift to a lot of men. Now, taking one step back. So with BPH, with this condition, most men, if they start having these urinary symptoms, and we talked about this on prior episodes, a slow stream, needing to strain, maybe it starts and stops, maybe they're getting up more at night. Most men first will maybe go to their primary doctor. The primary doctor might prescribe some medications that we went through before in a previous podcast. But when does surgery start entering the picture for these men that are bothered by BPH symptoms?
Yes. So, there's really two kinds of men that are bothered by BPH. There's the guy that is slowly retaining urine and just doesn't notice it, and then ends up unable to urinate and maybe even kidney damage. And then there's the man who has a lot of symptoms. They're going often, they might be leaking urine. They're just going every few minutes and their bladder is very irritated. Surgery comes into play when you have one of the following situations. You're unable to urinate, you're retaining large amounts of urine, you're developing stones in your bladder, you have blood in the urine, your kidney function is damaged. That is an absolute indication for surgery.
Right.
Relative indications for surgery are you don't want to take the medication, you don't like the medication, you don't like the side effects, or it's cost prohibitive, or you're just a person that doesn't like to take medication, but you have significant symptoms. You're a surgical candidate. So really, any man who is significantly bothered by their urination and don't want to take medication are candidates for surgery.
Got it. No, that helps a lot. Now, when men think about surgery for BPH, they talk about the old Roto-Rooter. That's kind of what a lot of men think about it as people talk about on the internet. That usually refers to a TURP, or transurethral resection of the prostate. Is a HoLEP the same? And if not, how is it different?
I have to say that I get this question almost every day. So I'm glad you asked that.
I'm on point. There you go.
Yeah. So because most people know someone who had a TURP or a Roto-Rooter.
Right.
So there are similarities between TURP and HoLEP. They're both done with a scope through the penis. They both remove prostate tissue, but beyond that, that's it. So with the TURP, you go in with a cutting blade, usually using cautery or electrocautery, and you just slowly shave out the inside of the prostate. I liken it to like a deli shaver. You're just shaving off layers of the prostate until you get the channel open enough that it looks like there's no more blockage, and then you stop. A HoLEP, you again use the scope, but you're using a laser that goes through the middle of the scope, and it cuts like a knife. So like a very precise knife. And I'm able to cut down to the capsule of the prostate and then just peel out the center of the prostate. Prostate's a lot like an orange, and it has a pulpy center. and then an outer rind. And I can just completely peel out all of the pulpy center, leaving you only a thin rind behind. So there's no judgment on my part. I'm not looking at it and saying, oh, that looks good enough. There's only one way to do it. And it's just like peeling an orange. There's really only one way to peel an orange. So you get a lot more tissue out with the HoLEP than you do with the TURP. Also, when you're going in and shaving, you're shaving through a lot of little blood vessels, and you can get quite a bit of bleeding with a TURP. With the HoLEP, I'm getting down to those blood vessels where they enter the capsule. So I'm able to control them with the laser in a pinpoint fashion. So there's a much less bleeding and a faster recovery with the HoLEP as opposed to the TURP.
Got it. Well, that's actually a great visual with that rind. So one question I know I get a lot, even with Roto-Rooter or laser, they say, Doc, you know what? You're telling me this urethra tube goes from my bladder all the way to the tip of my penis, and this donut is surrounding it. But if you're going to shave away the donut or cut away the pulp, as you say, where's the pee going to go? Isn't it just going to go all over the place? The urethra is not there anymore. What's going to happen?
Yeah, I get that question every day too. So the urethra, I tell my patients to think about the urethra like skin. Okay. So it's just a thin cell layer that runs through the middle of the prostate. So I'm actually cutting the urethra out in that portion. So then you have the raw surface area of the prostate, and the urine runs through there. As it heals, the urethra will fill in over that new surface. So it's a lot like if you skin your knee, you have a big patch of skin that's gone, and then the new skin grows in from the edges and resurfaces that area.
Got it. And I guess the difference is that instead of peeing through a pinhole formed by that donut, you're peeing through a much bigger space, but it's still lined by the appropriate surface, and the pee's not going everywhere. For the concern,
No.
that would be pretty bad. But I'm glad you could provide that reassurance to our listeners for sure. Now, one thing you mentioned, I also, just to clarify, because this is also a point of confusion among guys, is that, or at least guys that look on the internet, you mentioned that HoLEP is done with a laser. Now, there's another BPH procedure called the green light laser that's out there a lot. Can you explain what the difference between the two are, so that, because I know there's a lot of confusion of one versus the other?
Yes, there is. And so there's two types of laser procedures. There's ablative procedures and then enucleation procedures. Ablative procedures would be like HoLEP, green light ablation, THULAP, thulium ablation, any of those ablation procedures. And what they do with the laser in those scenarios is the laser settings are changed a bit, and it's used to, for lack of a better term, burn the surface of the prostate and cause the tissue to evaporate. This is technically not that difficult to do. And there's not a lot of bleeding, but again, it's a judgment call. So you're burning tissue until you think it looks open enough, and then you stop. And there's a limit to how much tissue can be burned or ablated in one setting. So that's the green light or HoLEP or THULAP procedures. And the other realm is HoLEP or enucleation procedures. And with enucleation procedures, we're using the laser at different settings to cut. So it's basically just a knife that cuts the tissue, and we use the scope to core out and push out the tissue. So it is technically much more difficult, but you get a much better outcome because you're not, there's no judgment call. You're just coring out that pulp until you get down to the rind. And then we have another device called a morcellator that chews up that pulp and removes it from the body. And it's sent to the pathologist. We can look for cancer or any other conditions that may be in that tissue. So one physically removes the tissue, the other one burns it.
And it sounds like the HoLEP is much more definitive based on what you're saying, because there's no gray scale about, did I do it? Did I not do it completely? You keep working until basically it's just the rind that's there.
Exactly. There was a great study that was done out of Canada. They were one of the first places to ever do HoLEP, and it's been around since the late 90s, actually. And they followed men for 18 years, and 1% of the men needed a repeat prostate surgery.
Wow.
Yeah, 1% over an 18-year period. And that's pretty significant if you think about the fact that your prostate grows at least 2% per year throughout the course of your lifetime.
Right.
So if you get enough tissue out, you should never need another treatment.
That's actually great to know, especially given the, and we'll talk about this a little later, but especially given the newer, what's called missed procedures, where there's a lot of marketing for them, but the downside of them, from what I understand, is that the recurrence is much higher. But
Exactly.
we'll dive into that a little bit later. Now, in terms of men who are considering surgery, another thing you see online a bit and here is that who's the ideal candidate for HoLEP? Sometimes you hear on the internet it's only for men with really large prostates. Other places you hear no, anybody can get it. For somebody who does so many of them, who is your ideal candidate for surgery for a HoLEP?
Yeah, so that's a great thing about HoLEP is that it is non-discriminatory. I mean,
Okay.
your prostate can be 20 grams, your prostate can be 500 grams, and you will get the same outcome with a HoLEP. It can be applied to any patient. So as long as you have symptoms related to an enlarged prostate, you're a candidate for HoLEP.
Mhm.
It's safe in men who have bleeding disorders or take blood thinners. We don't have to stop the medication.
Okay.
It can be done under a spinal anesthetic in case someone is too ill to have general anesthetic. So it is widely utilized. It's highly unusual that we find a man who cannot undergo the procedure.
Well, that's really good to know, because there's a lot out there about it's not for this, it's not for that. So I'm just going to make a blanket statement. So if a man is eligible for a TURP or a UroLift or a Resume or you name it, they're eligible for a HoLEP as well. There'd be a good candidate across the board. I mean, obviously there's nuances, but on a general level.
On a general level, yes. So, a lot of the other procedures require pretty extensive testing before
Mhm.
you decide to do it. And with the HoLEP, it does not, because we don't care about the size. So we don't need an ultrasound or an MRI or anything along those lines. The bladder function can be very weak and you still urinate because we are removing so much tissue. So we
Mhm.
don't do urodynamic testing or, pressure flow testing. And it doesn't matter what the configuration of the prostate is. So we generally never do a cystoscopy. So
Got it.
we just have a scope exam. So we just have men come in, we assess their symptoms, we screen them for prostate cancer because we, clearly do not want to miss an undiagnosed prostate cancer.
Mhm.
And as long as there's no risk for prostate cancer and their prostate is enlarged and they have significant symptoms, then we can go forward with surgery.
Got it. No, that's actually great to know. So basically, if a man comes in thinking that he wants HoLEP, aside from symptom check, maybe obviously doing a rectal exam, I'm assuming,
Yeah.
checking for prostate cancer, just to repeat, there's no other diagnostic tests usually that are needed or required.
Correct. The only time I will do other diagnostic tests is if the clinical scenario doesn't really make sense. They're younger, they have a lot of voiding symptoms, and their prostate doesn't feel significantly enlarged. Then I want to do a cystoscopy to look for maybe a stricture or something else that could be causing their symptoms.
When
So
it
if
just
you're a
doesn't make
younger
sense.
patient, yeah, if it
Mhm.
doesn't make sense, if you're a younger patient and you're having significant symptoms, you're probably going to get a more extensive workup than if you're 75 and come in and, it's pretty obvious what's going
Cer-
on.
Certainly. And yeah, again, it sounds like you're pretty open to most patients with BPH. Are there any contraindications to HoLEP that we should be aware of at all?
Um, so they're not contraindications, but there's situations that make it a little bit more difficult.
Mhm.
So if someone has undergone surgery for erectile dysfunction and have like a penile prosthesis, that
Mhm.
makes it difficult. We usually have to do those surgeries through an incision in the perineum or behind the scrotum.
Mhm.
So it requires an incision. If patients are really obese, they're very large, that
Mhm.
can make it difficult, and we have to do it through the perineum as well.
Got it.
Um, but really, you can get the HoLEP done in most anyone if they have too much cardiac disease that they're not even a candidate for a spinal anesthetic because of the concerns of fluid shifts. Those are the patients that we really can't do a HoLEP on.
And one more scenario I want to run your way. So again, we just mentioned, again, for some of these missed procedures, shortened period of time in terms of durability, maybe the symptoms come back a few years later, sometimes even sooner.
Mhm.
Could you do a HoLEP on somebody who's already undergone a UroLift or resume, or is that a contraindication because the anatomy has changed or maybe something's kind of different there?
No, so I do a lot of HoLEPs after a previous procedure, whatever that might be. So I've done a HoLEP after every type of BPH surgery except a HoLEP. I've never done a HoLEP
Well,
after a
that makes
HoLEP.
sense, right?
But
That makes
PAE, UroLift, Resume, tuna, microwave ablation, TURP, aqua ablation. I've done HoLEPs after all of those procedures. Surprisingly, they rarely make it any more difficult because they're not getting down to that capsule. So that plane is really undisturbed. So it's very easy to go ahead and do the HoLEP. And patients have, we've studied these patients and they have similar outcomes as to someone who has never had a prior surgery. So you can still get a great outcome even if you've had a prior procedure.
Oh, that's great to know, because a lot of men feel like they're kind of boxed in once they've had the one procedure. They don't really have any other options, but it sounds like they do, and it sounds like they have a great one.
Yes.
Now pretend I'm your patient and I'm coming in for a HoLEP consultation. I say, Dr. Krambeck, this sounds great, but what are the risks of HoLEP? What should I be worried about?
So there's three main things I always talk to my patient about. The first one is bleeding. So it's almost unheard of that you would ever need a blood transfusion with this surgery, but you are going to have blood in the urine for a period of time. Most people, it's 3 to 5 days, but other times it could be up to a month if you're taking blood thinners. So you have to know that you will have bleeding, you will have blood in the urine, it will go away, but that is a risk. The second risk is urinary leakage. So because I'm taking out so much tissue, there's nothing really holding it in other than the muscle or the sphincter. And a lot of men haven't used their sphincter in years because their prostate has been acting like a plug.
Sure.
Some people, it kicks in just really quickly and they have no issues, and other men do have temporary leakage. It's about 30% of men will have temporary urinary leakage or incontinence after the procedure. That heals, that goes away as they heal. Most men, it's gone by 3 months.
Okay.
The likelihood of it being permanent is 1%. So very low risk of permanent leakage, but you may experience that temporary leakage. And then the one thing that I say is the true drawback to HoLEP is retrograde ejaculation. So anything that's going to go in and open you up fully is going to run the risk of causing that. And just to clarify for the listeners, so a retrograde ejaculation, it means that you still have erections. Those are not affected. They're not worsened. So what you came into the surgery with, you leave with. You still climax an orgasm, but you're not going to see the semen come out. So that is an adjustment for a lot of men, and they have to be willing to accept that going into the surgery. It's irreversible. So, quite a few men experience that with the medications. So they have an idea of what they're looking at, but it is something that I take a lot of time counseling them about.
Yeah, so I want to unpack that a little bit, because this is the retrograde ejaculation public service announcement that men need a lot of reassurance on.
Yeah.
So we've talked about this before, but we'll talk about it again, just because this is something that I know I hear about 100 times a day. So I'm sure you do as well. So I really want to be clear. So first of all, with HoLEP or other prostate surgeries, why does retrograde ejaculation occur?
So, it's actually quite an area of debate. We don't know 100% what leads to it. Based on what things look like, what the in surgery looks like after HoLEP, I can tell you that there is nothing blocking the bladder neck after the procedure. So semen comes in through the ejaculatory ducts, which sits right in the middle of the prostate. And those are not injured during the surgery. But the bladder is right there, and there's nothing blocking the bladder anymore. So there's not any pressure to keep the semen from going into the bladder. And so it just takes the path of least resistance. So it goes into the bladder. The next time you urinate, it comes out. So there's no longer that blocking prostate tissue that creates that pressure difference and forces it up the tip of the penis.
Got it. And so what happens to that semen? Does it, because another thing that I get asked is, okay, the semen still is getting produced. It's going somewhere. What happens to it? And is it dangerous to me?
Yeah, I get that question too. So it goes into your bladder. So if we were to take the urine after you have intercourse and spin it down and look for sperm, we would find sperm in the urine. So it's going into the bladder, mixing with the urine, and then you urinate it out the next time you urinate. It doesn't hurt you. It's your own body's natural substance. So it's not causing any harm. And it doesn't really make any difference to your overall health.
Last question about retrograde ejaculation. You're really, all of your semen supposedly is going into your bladder. You're peeing it out later. Does that mean you can safely consider yourself infertile, or meaning you don't need to have protected intercourse anymore?
Yeah. No. Because so it's still, 3 to 4% of men still can produce some ejaculate after surgery. And we don't know when they do, like they may go a year and not see any ejaculate, and then all of a sudden they see some. So this surgery is not done to create infertility. So when you're relying on a side effect of a surgery for your outcome, that's never a good thing.
Right.
So you can't consider
just that fringe benefit.
Yeah. No, especially something as important as pregnancy. So you still need to, use protection. Your partner, cannot be fertile because there is still a risk of fertility, of impregnating someone, because you could theoretically produce semen.
Got it. No, that's actually a great explanation. The other thing that often gets confused with prostate surgery, HoLEP included, is that men sometimes confuse that prostate surgery with prostate cancer surgery. Yes. And with prostate cancer surgery, the big question that comes up is, listen, I really have trouble peeing. This surgery sounds great, but I don't want to have erectile dysfunction the rest of my life. This is going to be horrible. What do you say to that in terms of the difference between HoLEP and prostate surgeries for BPH versus prostate surgery for prostate cancer, and the difference in terms of side effects?
Yeah. So prostate surgery for prostate cancer requires that you remove all of the prostate. And to remove all of the prostate, you have to take off or move away the nerves that run to the penis, and they sit on the surface or the capsule of the prostate. So there's quite a dense nerve network that sits right over the surface of the prostate. So because it's cancer and cancer is life-threatening, we accept those risks and we move the nerves and we take the prostate out, and then we sew everything back together. With BPH, there's no real risk of death. This is a lifestyle surgery. So we don't want to take those risks. So what we do is we just core out the center of the prostate and leave the capsule. And what does that do? Well, that spares all of those nerves. So the nerves that supply your erection or help control your urinary continence or dryness, they are not disturbed. And so there's no injury to the nerves and hence no effect on your erections.
Got it. So very, very different scenario. Just using your own example, for prostate cancer, instead of just taking out the pulp, you're removing the entire orange. And that is a much more involved procedure. Much
more involved. Yes.
Got it.
Now, on the same vein of prostate cancer, I do treat quite a few men who do have prostate cancer that are on active surveillance protocols. So they have a low-grade prostate cancer, have decided to just monitor it. That you can still go on and have a HoLEP if you have symptoms, of difficulty urinating and so on.
Well, now you just opened the door for this question then. So I was confident, should I ask it or not, but now I have no choice. So, a lot of men who might be on active surveillance, and for all those listening, for some prostate cancers, they're so mild, they don't require active treatment. We just keep an eye on it through active surveillance. And for men who don't even have prostate cancer, but think maybe they might, the question often comes up is, doctor, you're saying I do or I might have prostate cancer, and you're going to put my prostate through a blender? Isn't that aren't any of these prostate cancer cells going to be spread all throughout my body if you cut into those cells?
Yes, and that has come up as a big concern, especially with what we've seen in gynecology and their issues with their morcelators. So
yes.
Many men have with active prostate cancer who are on active surveillance have undergone HoLEP, and we've not seen one case or any evidence to indicate that it worsens the prostate cancer or that the prostate cancer will seed into the bladder or the urethra. It really just does not appear to cause an issue. And I think it's because we're keeping the urinary system intact.
Mm-hmm.
So everything is kept inside the bladder and urethra, and those areas are already exposed to the prostate cancer anyway, because it's all connected.
Got it. Got it. Because you're not going outside of that capsule. You're not going out of the linings. It's all contained within the box, basically.
Exactly.
Got it. So now what I want to do is I want to walk through a little bit of logistics in terms of HoLEP, because for guys, it helps a lot for them to understand kind of exactly what they're signing up for in terms of the process, right? So the first question, just again, in terms of logistics, if I sign up for a HoLEP with you, for instance, is there any preparation I need to do prior to the surgery?
Yes. So prior to the surgery, I would require that you have a urine culture.
Mm-hmm.
You may require a week of antibiotics prior to the procedure, depending on if you have a catheter in or your culture is positive or you have a history of infections.
Mm-hmm.
And that is really the only preparation. The night before surgery, we would ask you not to eat or drink anything, after midnight, and then you would come in for your procedure. Now, the way I do HoLEP is a little different than other individuals across the United States, but I send my patients home the same day without a catheter.
Wow.
Yeah. So they would come in, they would have their procedure. They would wake up with a catheter in their bladder. We would watch them in our extended recovery area for 2 hours. And if the urine color is light enough, then we would take their catheter out, let them urinate and go home. So it's
Mm-hmm.
about 85% of the men that I treat can go home the same day without a catheter.
Mm-hmm.
We'd ask them to not do anything strenuous for 1 week, drink plenty of fluids to stay flushed, and make sure that the bleeding stops, within that week. If at
Got
the
it.
end of a week they don't have any bleeding and they're feeling well, then I will let them go back to half their normal exercise regimen. So, if they walk 5 miles, they can walk 2.5. If they lift heavy weights, do about half of what you normally do for another week. And then after 2 weeks, you can do everything you want.
Yeah, it sounds like a pretty quick recovery. And most guys with desk jobs are going back to work pretty soon, I'm assuming, right? Almost immediately, I would assume, right?
Yes, like within 24 to 48 hours, they're back to their desk job. Now, it's variable as to how much discomfort you will have. You shouldn't have like a throbbing or aching pain. It should be nothing like that. But about 12% of men will have burning with urination. So it feels
Mm-hmm.
like pins and needles or fire when they urinate. And
Mm-hmm.
that can last for several weeks. There's medications we can give to help with that, but patients don't require narcotic medications. They really feel quite good. And that's kind of where we run into trouble, because they feel so good. They go back and start doing all their activities early.
And that's when, trouble they get a little too excited. It's like the guy who has a vasectomy and then takes his kids to Disneyland right afterwards. That type of
Exactly.
scenario.
Yeah.
When the procedure goes just too well, that's when those kind of situations occur. Now, it's pretty amazing that for people to go home the same day, just in terms of understanding, at the time of surgery, how long does the procedure usually take to perform?
It's all based on the patient's prostate size. So smaller prostates, less than 80 grams, it may be a 35, 40-minute surgery.
Mm-hmm.
If you have a monster prostate, 300 grams or more, it could be 3.5 hours.
Mm-hmm.
I tell my schedulers use a mean of an hour and a half OR time. And that that will just encompass the small and the large and the all in the same. So
Got it.
not very
And
long.
for those listeners out there, what's the because you mentioned some ranges of what's the typical prostate size for a man?
So, if you were to look in a textbook, it would say 20 to 30, but that's a younger man.
Yeah.
As you age, you would guess around 40 to 50 is
Mm-hmm.
what we normally see. My practice is a little bit different because I do HoLEP. So most of the prostates I treat are around 100, 150 grams because they're referred from other urologists.
Right. And before, I remember back in the day when I was young, I remember that those men with really large prostates like that would require open surgery.
Yes, yes. So even when I was training, I did quite a few open simple prostatectomies. That's what you did, because once you get above 80 grams, most of the lesser invasive procedures either don't work as well, or you can have significant bleeding complications because the prostate is so vascular or has a lot of blood vessels in it. So once you get above 80 grams, your options are limited. Now, nowadays we have HoLEP, we have robotic simple prostatectomy, we have prostatic artery embolization. Those are the three that are often used for larger prostates.
Got it. So that actually begs another question. First of all, in terms of if I'm a man and I have a 200-gram prostate, is it reasonable for my urologist to tell me I should get an open prostatectomy? Or if I'm told I should get an open prostatectomy, should I seek another opinion?
I would suggest seeking another opinion. An open prostatectomy involves cutting your abdomen open, cutting open your bladder, coring out the inside of the prostate, and then sewing everything back up. So you're looking at a minimum of a 6-week recovery time. You're going to have a catheter in for 7 to 14 days, and you have a real risk of significant blood loss doing that procedure. It's a big surgery.
Right.
And nowadays there's other options. So there's not a lot of people who do HoLEP, but there's a lot of people who do robotic simple prostatectomy, and that's at least less morbid than an open prostatectomy. So I think that if it's suggested that you do an open simple prostatectomy, I think it's just worth your time to step back, slow down, and get a few other opinions.
That's a good point. And I'm not sure if you know the answer to this question, but I'm assuming I don't do HoLEP. I'm assuming a lot of urologists don't do HoLEP. Do you know like what percentage of practicing urologists in the States today do it? If you had to do it, take a guess.
I would guess it's probably 1% of
1%. So
yeah,
it's a very specialized procedure.
It's very specialized. Yes, but it's actually becoming more and more common. There's more people like me that are training fellows, and then we're also training residents. So when they leave their practice, many people have an idea of how to do it and can adopt it. So we're seeing a big uptick right now in people doing HoLEPs.
And I want to stress the reason why. And so people don't get confused, and this is something that you brought up, but I do want to stress. Some people think, well, a lot of people aren't doing HoLEP because HoLEP is not as great a procedure as if you will, Resume or Urolift or anything like that. But in reality, it's by the sound of things and by the data, it sounds like a fantastic procedure. It just requires a tremendous amount of skill by the surgeon to do it versus those other procedures which are a lot easier to perform, but may not be as effective. Would you agree?
Agree. It really comes down to training. So HoLEP takes about a year of dedicated learning to learn how to do it beyond your own urology training in medical school. So you have to spend another year of your life learning how to do this procedure. And that's whether you go do a fellowship or you are even self-taught. You're really going to slow down your life to learn something new. And that's hard to do, especially when there is all these other options that you can offer, and you don't have to do that dedicated training to do it. So that's the biggest hurdle with HoLEP. It's not the outcomes, because the outcomes are amazing, but it's the amount of time that you need to dedicate to learn how to do it.
Got it. 1% of surgeons, not a lot. You go on the internet, you find, you're not next to Dr. Krambeck, you're on the other side of the country. You find somebody online who says, I do HoLEP. How do you vet that urologist or that surgeon? What kind of questions do you ask? What are the criteria to say, you know what, this person knows what they're doing?
Yes, I would ask them how many procedures they have done. You really don't want someone who's in the first 100 cases. You really want someone beyond that 100 case. That's where you start to plateau and get really standardized outcomes. You want to know what their average operative time is. So, you don't want to be asleep for 4 to 5 hours having your prostate treated. This should be an hour surgery.
Right.
Maybe an hour and a half to 2 hours, I think, is a reasonable amount of time. And then ask, what is their blood transfusion rate and how long is the catheter left in? These are all legitimate questions that they should be able to answer.
Got it. And it does it matter? Like, let's say the surgeon says I've done 105 of them, but does it matter how much they do every year?
Yeah, the number they do every year and how frequently they do it is important.
Mhm.
So there was a really interesting study done where they looked at the surgeon who did HoLEP and they looked at their outcomes. And this particular surgeon had several breaks, like they had a baby, they moved practices, they took some time off to do research, and every time that surgeon took a break, the patient's temporary leakage went up.
Mm.
So when she started operating again, a few weeks after her breaks, the temporary leakage rates went up and then they went back down. So it is a highly skilled procedure that requires that you do a lot of surgery consistently. You don't want a surgeon who does one a month. That's
Right.
not a good thing.
Right. And you also you had mentioned obviously you don't routinely include catheters after surgery, but you said one of the questions to ask is about catheter rates and catheter times. What can you give us some parameters in terms of what for those surgeons that do leave a catheter, how long should it be in, what's considered normal, abnormal, within range, of course.
I would say 24 hours is a normal range for a HoLEP. So
Mhm.
if they say, well, I keep the catheter in overnight, we take it out the next day. That is truly the normal range.
Mhm.
I think I'm outside the normal because I've just done so many, I can get the bleeding down to a point we can take it out the same day. There's a
Mhm.
few other people that do that, but the vast majority of people will leave it in overnight. Now, if
Mhm.
they say you have to be on bed rest and we don't take it out for 3 days, that's abnormal.
Yeah. I'll
And
say so.
that would be maybe not the person to do the procedure.
Got it. Got it. And then with we had talked about the mist procedures, which are very hot right now. Everyone's talking about them. They sound pretty compelling. Come into the office, we'll just put in a catheter and you'll get it all taken care of. And again, I'm old enough to remember when older mist procedures came out as well. But I wanted to hear from you in terms of when I have no doubt men come to you and ask this question: how does it compare to Urolift, or how does it compare to Resume? Why would I go under general anesthesia when I can, or even spinal when I can do it in the office? What would you say to men who are coming with that, with those questions to you?
Well, when you compare to Resume, your catheter is actually in a shorter period of time with a HoLEP than with most Resume patients.
Right.
So that I don't even really consider that as a comparison because it's, you know, yes, it's done with you awake in the office, but you have to think about what you're experiencing while you're awake in the office. And I try
Indeed.
to, and and so most people would choose to be asleep for that.
Right.
But here's what I tell patients. I'm like, yeah, you can get a Resume or Urolift, but you have to think about that as a bridge to something else. It's not a definitive therapy. So if you tell me, I don't want to take medication, I understand that I'm probably going to need another surgery in a few years, but I'm just not ready for the big procedure. Then I'm like, fine, go get a Resume or Urolift, come back to see me in a couple of years and we'll do the definitive procedure. Um, the benefits of Urolift and Resume is that they do not cause retrograde ejaculation at the higher rates, like what we see with HoLEP. So
Mhm.
if you have a patient who just cannot accept their retrograde ejaculation, then that might be a nice bridge for a few years for them.
Mhm.
But the vast majority of the time, they just want this fixed and they want it fixed for good. And
Right.
once they hear about the long-term low retreatment rates for HoLEP and the minimal downtime, they almost invariably just choose HoLEP.
Got it. No, that you make a very good point, because again, when the biggest selling point is get this done awake in the office, most guys don't like a rectal exam in the office. Forget about a procedure that might be going on for minutes. And at the same time, as you mentioned, lower catheter times, more definitive,
Mhm.
certainly sounds convincing to me. Now, can you do the head-to-head also of HoLEP versus Roto-Rooter or TURP? Because that's the more common procedure that's been done for decades.
Yeah.
Do a head-to-head for me if I'm shopping around for surgery for one versus the other.
Yeah. And so we're very fortunate that HoLEP was developed in New Zealand because it's a country outside of the United States. So they could do prospective randomized studies. They could just bring patients in and say, no, you're getting a HoLEP, you're getting a TURP. And
that would
so
totally work here.
would never work in the United States. But there, the patients were like, okay.
All right,
so
yeah.
we have a lot of data from New Zealand. And in those studies, TURP didn't do poorly. HoLEP just did better.
Mhm.
So the HoLEP patients had less blood loss, shorter hospitalization time, shorter catheterization time. There was no difference in urinary leakage, no difference in scar tissue formation, and no difference in erectile dysfunction.
Mhm.
So immediately the patients did better with HoLEP. Then they followed them for 7 years. And at each time point, the patients who had the HoLEP had a better flow rate. So their urine flowed out faster. Their symptom scores, so the AUA symptom score, which is this survey that we have patients fill out to get a number as to how bad their symptoms are, their AUA symptom score was better at each time point. Furthermore, none of the patients in the HoLEP group needed a retreatment versus 3 patients in the TURP group over the 7-year period. So it's just more definitive. And I'm not going to say that a Roto-Rooter is bad. I'm just going to say the HoLEP does better.
Makes sense. And again, do you attribute I understand the short-term benefits, the long-term durability, you attribute that to, again, the Roto-Rooter is still, even though it's using a blade, it's still chipping away, and it's not kind of more elegantly really making sure you're at that rind of the orange throughout the course of the prostate.
Exactly. So it's still TURP still is like an art form, right?
Mhm.
So you are going in and there's really good TURP surgeons. I mean, extremely good TURP surgeons. But they're shaving until it looks good by their eye. And then they stop. Whereas with a HoLEP, you get into the plane and you follow the plane and there's no judgment. It just does it on its own. So it is a thorough enucleation that the patient's body is telling me what to do.
Right. Now a tough question, a practical question, right? So this all sounds great. And you know what, let's say I want to get a HoLEP, or I'm not quite sure. If I'm a man that I know I'm ready for surgery, the options available to me are very different in Los Angeles, California versus New York versus Des Moines, Iowa, right? What would you recommend for somebody, for a man who's thinking about, he's educated about this, he's learned about HoLEP, he's learned about MIST, but you said that only 1% or so of urologists, for instance, perform HoLEP. What resources are there available that you know of that they can say, how do I find that right surgeon for me?
Well, that's the beauty of the internet. The beauty of the internet is you can get anything anywhere, right?
Right.
So most patients, a lot of my patients come from out of state. Like a lot of people who do HoLEP have a system set up at their hospital where they can do a telemedicine evaluation of a patient in Alaska and evaluate them, see if they're a good candidate, and then arrange for their trip to get the HoLEP in a short period of time in town and go back. The other thing you can do is some of the companies have websites where you can put your location in and what you're looking for, and they will, like the laser companies, and they'll direct you to someone that they think is a quality surgeon in your area. So if you get on the internet and you look for HoLEP and you look for HoLEP surgeons, you will find people that that do it nearby or across the globe or whatever you're looking for, and then just contact them. Most of these places are very easy to get in touch with, and they have a system in place to get you what you need.
Got it. And then you just know, then you're armed with the questions you need to ask to make sure that they're the right surgeon for you.
Exactly.
So Dr. Krambeck, thank you so much for this very enlightening discussion. I think you've educated a lot of people about kind of what HoLEP has to offer, and really demystified, no pun intended, a lot of the myths about what's going on in terms of BPH treatment. Now, my last question has nothing to do with BPH, urology, or HoLEP. It's a question I ask to all of my experts that come on the show. As a very successful surgeon, doctor, person, what is your key to success and to living your best life?
My key to success is I live by the mantra that life is short. And
Mhm.
so you need to do it now and not wait till later. So I take every possible opportunity to experience life, travel, talk with my patients about, what their lives are like, and seize new opportunities. So that's how
I
I
think
live my best life.
I think that's some pretty darn good advice. And so, Dr. Krambeck, thank you again so much for your time and for educating us about HoLEP. And for everyone out there, just remember our mantra, which is your best life is a journey and not a destination, and use every day to just get just a little bit better. Thank you for joining us, and we'll see you next time.